Okay, we'll begin our program in just a moment. Welcome everyone to our Dementia Education Conference. We'll begin in one moment.
Good morning, everyone. Welcome to day 2 of our 23rd Annual Dementia Education Conference. I'm Ginny Hambridge, Executive Director of the Connecticut Chapter. We hope you enjoyed the varied and inspiring sessions that happened yesterday. I know I learned a ton. They were so wonderful, and we hope you did too. And the great thing is that they were all recorded, so you'll get a chance to see them again or see them for the first time if you were in another session. Again, thank you to my staff and all the volunteers that put together this fabulous conference. Another big shout out to Carolyn DeRocco and Stacy Chavez for all their hard work in putting this event together. We also appreciate our wonderful sponsors who made this event possible. Our gold sponsor is Next Street Driver. Please visit them. Our Next Street Driver Rehab Services, wanted to get the title right. Our platinum sponsors are Hartford Healthcare and Yukon Health Center on Aging. And we send a very special thank you again to our presenting sponsor this year, Chatham Place at Mary Wade.
Hello, everyone, and welcome to the Alzheimer's Association Connecticut Chapter's 23rd Annual Dementia Education Conference. I'm David Hunter, and I'm the President and CEO of the Mary Wade Home and Chatham Place here in New Haven, Connecticut. And we are proud to be the premier sponsor this year. We have a long-standing, strong relationship with the Connecticut Chapter, and we are very excited to help bring this knowledge and support-based evidence training to you virtually. Education is key when dealing with this disease. We here at Mary Wade Home and Chatham Place understand the needs of the caregiver and know you need a safe place for your loved one to live. We work very hard in our skilled nursing center with the training of our staff on dementia care, and find it extremely important for those with dementia to have a place where people understand this disease and understand the dementia that comes from it. We also find it's very helpful to our families when our staff are educated because we can provide that education to them as well. We are also excited to be announcing the beginning of our new assisted living and memory care building, which we call Chatham Place at Mary Wade. It's currently under construction, and it involves 64 assisted living apartments and 20 memory care apartments. And so we look forward to expanding the services that we do provide for those who are suffering with Alzheimer's disease and other dementias. The vision of the Alzheimer's Association is a world without Alzheimer's and all other dementia. We all want that to become a reality, don't we? As the researchers work to find new treatments and a cure, we are here for you and your loved ones. The Alzheimer's Association and their resources are too. And have a wonderful conference, and thank you for being here with us.
Thank you, Ginny, and thank you, Mary Wade. I'm Carolyn DeRocco, Vice President of Programs and Education for the Connecticut Chapter. I want to thank so many people, my wonderful staff and all the volunteers, and also especially our Dementia Education Conference Committee. We cannot do this work without you. It really does take a village. So I want to say thank you so much. So today is day 2. I hope you enjoyed yesterday and soaked in all that knowledge. I went around to the exhibitor booths, and the handouts alone are just so informative. So make sure you really take the resources today. to be able to help your patients, your clients, and your residents, your family members that are living with Alzheimer's disease or related dementia. Again, a couple of things. As you visit the booths today, you can visit between 11:45 and 12:15. Again, please make sure you go around to visit those booths. If you visit each and every one of those, you can enter into a fun drawing for free registrations for next year's conference. So that's wonderful, exciting news to share with you today. Also learn about what's happening in Connecticut. We have our Connecticut chapter booth. You'll be able to learn about our Walk to End Alzheimer's, when are all those dates, our longest day, our Women to End ALS, advocacy opportunities, volunteer opportunities. So we want to make sure you can continue to look at resources and know how to join our family. After the session this morning, again, you'll go to your schedule to access your next sessions. Just some important housekeeping and so information for CEUs. You do have to attend the entire session. It is being logged, your time, so make sure that you are in that session for the entire time slotted for that. For CMEs, you will receive an email from Continuing Education from Hartford Healthcare. That'll be an email after the conference. You will need to note this down. This event code is 22612. Again, for CMEs, the event code is 22612. One thing I also want to make sure you take a moment today. I know you're going to be busy running in and out of sessions, but the adult day centers have beautiful artwork that are created by those living with dementia. Again, take a look at those and just remember the sense of purpose that they have, that they're still doing things, and that your work, your time, your dedication, and all that you commit to has really helped them strive and to feel that sense of purpose. I want to thank you on behalf of all of us at the Alzheimer's Association for all that you do to care for those living with dementia. So soak up all the information today. I want to introduce Kristen Casato, our Communications Director.
Thank you, Carolyn. Hi, everybody. So great to see you here for day two. Very, very exciting. Now, we know from our Alzheimer's Association Facts and Figures report that comes out every March, and we had a special report this year, that discrimination is a big barrier to Alzheimer's care. And our plenary speaker this morning will talk about this topic and cultural competence as well. Throughout the plenary session, throughout this, please put your questions in the Q&A, and then we'll address them afterwards. Eme Martin, MPH, is the Regional Director for Health Systems with the Alzheimer's Association, a little down south in DC, Maryland, and Virginia. She's responsible for building strategic partnerships throughout that area, including with the Veterans Health Administration. A 2016 recipient of the National Minority Quality Forum's 40 Under 40 Leader in Health Award, Eme has more than a decade of experience working in different healthcare organizations. Thank you so much for being with us, Eme. We look forward to your talk.
Thank you so much for having me and for that lovely introduction. Happy Friday Eve, everyone. I'm excited to be a part of your second day of this wonderful conference. I'll begin sharing my screen and also share my sound, as there will be a few opportunities to engage beyond just PowerPoint. As Kristen mentioned, today's conversation will focus on cultural competence, particularly in this space, as we know through our recent report here published at the Alzheimer's Association, that there are challenges and discrimination in dementia care. I hope that this will be an opportunity for you to focus your energies and efforts in the space of being an advocate to improve the care of the communities you serve of all backgrounds. I have no financial relationships or disclosures to express. I want to begin our conversation because I do see it as that, even though I cannot see you, with an opportunity to level set with a brief vignette. I hope that you will open your minds to this brief video, which will be a few moments, and it's a bit light, but I hope that it will send an appropriate message. I'll go ahead and stop screen share and resume again to make sure that we can all see that video.
Hi there.
Hi.
Nice day, huh?
Yeah, finally, right?
Where are you from? Your English is perfect.
San Diego. We speak English there.
Oh, no. Where are you from?
Well, I was born in Orange County, but I never actually lived there.
I mean before that.
Before I was born.
Yeah, like, where are your people from?
Well, my great-grandma was from Seoul.
Korean. I knew it. I was like, she's either Japanese or Korean, but I was leaning more towards Korean.
Amazing.
Yeah. Hamshasina. There's a really good teriyaki barbecue place near my apartment. So I actually really like kimchi.
Cool. What about you? Where are you from?
San Francisco.
But where are you from?
Oh, I'm just American.
Really? You're Native American?
No, just regular American. Oh, well, I guess my grandparents are from England.
Oh, well. Hello, Governor! What's all this then? Top of the morning to you. Let's get a small tea, small tea! Double, double, toil and trouble! Mind the gap! Beware Jack the Ripper! Bloody hell! Pip pip! Cheerio! I think your people's fish and chips are amazing.
You're weird.
Really? I'm weird? Must be a Korean thing.
I hope you had an opportunity to digest a bit of that. And of course, with a bit of lightness, but also with hopefully a bit of perspective, as we've perhaps either been on either side of that conversation. As we move forward in today's conversation, I do hope that as I labeled this presentation a 365 approach to cultural competence and delivery, care delivery, that we will consider this the first of our many days where we will be a bit more intentional about how we deliver care that is culturally competent, that is patient-centered. We all are on a journey, and while that video, of course, is a bit of tongue-in-cheek, I think as we continue this conversation about what it means to be aware and culturally sensitive, that we will consider where we stand on the spectrum and how we can improve in our journey. So as we move forward through today's conversation, I want to first level set about patient-centered care and cultural competence. These are really sexy words, if you will, in the space of healthcare of late, and I want to make sure that we're all on the same page and from the same perspective as we have this dialogue. Then I'll talk about why the business case of delivering cultural competent care is so important, and what that looks like. And then we'll talk about ways that we can implement patient-centeredness in what we do as we engage with our patients and families living with dementia. So first, there are different ways that we can define patient-centeredness. And so we want to do so from a perspective of what is health care. The World Health Organization states that it's not just about not being sick. We all love it when we are able to get up in the morning, go forward with our day, no sniffles, no aches. And it's more than just that, but it's also the mental, the social, emotional well-being, and not just not being ill. And so when all those parts of us come together, then we can say we're truly healthy. Now, we know that when there are challenges and disparities regarding what health looks like between different groups, whether it's racial or ethnic or age or gender or language preference, that then we're finding that we're at odds, that different groups are experiencing disease outcomes in less or a greater burden than others. And so, for instance, when we think about those who may be native English speakers, we may see that in some areas they don't have as great or equal outcomes to perhaps other populations because there's a lack of health literacy, or we're not doing our parts to make sure that that information is conveyed appropriately, or not having language interpreters. Perhaps as we look at some other illnesses, we may see that there's, of course, gender disproportionate burdens, such as heart disease, where we know that women are unfortunately more or greater affected. The same is the case in dementia care. And so when we see those differences, those disparities make us take a step back and consider, why is that the case, and what can we do to change that? And that's where health equity comes in, making sure that we provide the conditions such that everyone has the opportunity for optimal health. And so thinking back to the example of language preferences, and seeing that perhaps one group of native speakers versus another does not have the same health outcomes, perhaps we can start making sure that we always have language access and interpreters available, multiple documents printed in languages that people can access to help change those differences and eliminate them. And so when we work towards health equity, we're looking to make sure that we provide the circumstances where health can happen optimally for all people. And I've listed Dr. Kamara Jones as the author of that quote and that concept, because she is a leader in the space of health equity. And I highly recommend, if you have not heard of her or not had an opportunity to look at some of her dialogues or conversations around health equity. She does a wonderful job in making analogies and making this concept very well and clearly understood. So I highly recommend Googling her. And so when we think about this concept of health and health disparities and creating health equity, we recognize that it's not just about the things we do in our care facilities, but it's the things that happen beyond our care facilities that really impact, or the determinants that influence person's health. We spend a few moments coming to an appointment or coming into a health facility, but it's really the things that we do daily in our work, in our environments, in our neighborhoods that contribute how healthy we are. And I bring up this image here because it really speaks to this idea often, and previous to this current moment we're having and this movement we're having, where we focus on the things in the four walls. We realize that only 20% of what we do inside of writing a script or a four-walled facility really impacts what happens in our lives and what influences our health outcomes. It's really the other 80%, where I live, the environments where I work, and the quality of housing and water, the economic factors, the access that I have to good and healthy foods, and behaviors that I take for good or for ill, that really impact my quality of life and my health overall. The things that we do, that we prescribe, influential for sure. We definitely need our medications. We definitely need some guidance from our health professionals, but that impact isn't as great as the things that we return to in our environments, in our homes. And so it's important that we as professionals understand that and are able to appropriately guide and support our patients to go back to environments or support them to meet them where they're at, to engage them and appropriately guide them to come up with the plans that are most suitable to their needs and that will allow them to have their best optimal health outcomes. Again, some of you have probably seen a diagram of similar sorts. We often see circulating the baseball game that speaks to the idea of equality versus equity. And sometimes we use these terms synonymously, but truly, as we look at the top row that speaks to equality, it's providing everyone with the same thing. And we see that sometimes that's not appropriate. Someone who's taller is going to need a bike that provides them the bandwidth and the opportunity to function at their highest level, or perhaps one that's adapted for their needs. And that's where equity and that lens is so important, that we meet people where they're at and that we deliver care that is appropriate and responsive to their specific needs. And that gets into the space of health equity and patient-centeredness and whole person-centeredness, that we don't just universally provide care that looks exactly the same to everyone who comes through our doors, but we look at one person and we see them as they are, and we meet them where they are. And that gets into the space of culturally competent care. What does that look like from a patient-to-patient perspective? And there's a couple of different definitions that speak to not just what it looks like as a provider, but also what your organization is doing to encourage cultural competence. From the practitioner, the one-to-one guide, it's understanding and acknowledging that there is diversity in those people who come through our doors. And that's more than just racial and ethnic diversity, but it's diversity of thought, beliefs, practices. Understanding and valuing that such that as we engage them, we can meet them where they're at and deliver care that is patient-centered and culturally appropriate for them. And when we work in an organization that supports that, they have behaviors, attitudes, and policies and practices that support that. They have bilingual signs, they have bilingual literature, they have information that allows us to meet people where they're at, to understand that perhaps they need a bus route that meets them where they can come and enter our facility with easier access because everyone may not have a car, and things of that nature. Organizationally, we are striving to create an environment where people can come and access care and feel that that care is culturally appropriate and tailored to their needs as a patient. And so when we think about cultural competence, why are we striving to deliver care? Of course, we here, many of us have hearts of gold, or striving to be our best selves, striving to deliver care that really gets at the heart of what a patient needs and their families. But sometimes it's important to understand the broader perspective. And as we see and as we know, as we can see in our own communities, our demographics, our nation is shifting and becoming more culturally and ethnically diverse. A couple of things to really highlight over this 20-year period, we see that the majority of white or and non-other racial groups, that category is shrinking almost by 10% within a 20-year period, which is significant. And that we're seeing more diversity in terms of racial and ethnic groups, as well as including biracial groups as well. Something to note on the right-hand side of this graphic is that our children are also becoming more ethnically diverse. And so as we consider the future and where we're going and how we're growing, it's important to understand that from a racial and ethnic perspective, it's important to see that we are racially and ethnically becoming very diverse and very much needing to be attentive to the needs of our growing population and our diversifying population here in the United States. But more than just in the United States, it's important to see how that affects us here at home in Connecticut. I'll take a moment to, again, screen share a brief video that was, excuse me for a moment as I manage technology, multitasking here. One moment again as I multitask again. Thanks for your patience. Here we go. And this news story was shared just at the top of this year. I'll go ahead and press play.
Connecticut is becoming more racially diverse, but younger people continue to move out west. That's according to some new federal data. Chief Investigator Len Bestoff finds out what that means for our state in his exclusive report.
Just in the past few weeks, the U.S. Census Bureau put the wraps on the national head count it does every decade. However, the agency also does population research every 5 years. It calls the American Community Survey, and that info is just out.
Households are surveyed across the country on a monthly basis.
Michelle Reardon-Nold with the Connecticut Data Collaborative drilled down on the data. One of the biggest Connecticut takeaways, we're getting older. Our median age, where half the population is above it and half below it, went from 40.3 years old to 41 years old. Reardon-Nold says a lot of the young people are migrating out west.
They are seeing a decrease in their median age, like Colorado, for example, Colorado and Arizona.
For example, Mansfield, the home of UConn's main campus, has a median age of 21. Retiree haven Essex had a median age of 55. While we have become slightly older as a state, Connecticut has also become more racially diverse.
So now we're at a third of our population are people of color, and that could be, biracial, could be Black, Hispanic, more than two races even.
Hartford is the municipality with the highest percentage of people of color, followed by Bridgeport and New Haven. Another data point that might get your attention, people without health insurance in Connecticut. We went from 9% uninsured to 5%.
Just thinking about less people uninsured in our state entering a pandemic, is a good thing.
While the feds did all this research, it's very helpful on a statewide basis on everything from taxes to education to housing. And we're going to have all this data that you can check out on the NBC Connecticut app. Len Bestoff, NBC Connecticut News.
Interesting information, and especially from the local perspective to understand who you are as a state and who you're becoming. Again, as we speak to this idea of being culturally competent and understanding that it's more than just racial and ethnic diversity, but understanding the growing and changing community that you're serving, these things help guide us as we deliver culturally competent care and patient-centeredness. From a business case in terms of dollars and cents, we know that being culturally competent has its benefits. We save money when we don't have errors, when we reduce readmissions and length of stays, and specifically when we're able to do those things that are patient-centered. For example, if we don't have an interpreter for someone who does not speak English as a first language, we may have errors in trying to understand with our kindergarten or our middle school second grade math, or math language. And we may make some errors and may make requests that are unnecessary if we just had an interpreter present. Or perhaps if we're not being sensitive to the fact that they may want more family involved in that conversation, they may not be willing to disclose things to us, which again may prevent us from making costly errors in terms of requesting testing or doing things that are not culturally sensitive to their needs. And recently, well, more than recently, over a decade ago, this published study came out from a leading thought organization, the Joint Center for Political and Economic Studies, that if we found ways to eliminate health disparities and specifically do those things that were patient-centered, that were culturally competent, that we could save over $229 billion with a B over a 4-year period. And so when we think about those things that are necessary to be culturally sensitive, to be patient-centered in how we deliver care, the dollar imperative is great, to say the least. We also know that there are federal regulations that support us in being patient-centered or culturally competent. Our friends at CMS certainly encourage training in this space. They also encourage and implore that we do things and implement procedures that are culturally competent for our patients and their families. The Joint Commission, of course, does regular reviews and also has a roadmap that speaks to culturally competent care from admission through discharge and post-acute care. And then, of course, there are regulations in the Civil Rights Act that support us being organizations that are culturally competent and patient-centered. As Kristen mentioned at the outset, we at the association just recently published our facts and figures with a special report that speaks to discrimination in dementia care, and I'll speak more about that later. But overall, we're improving patient experience. We all want those scores to go up in terms of quality and patient satisfaction, but we also want the best and perhaps not always recorded experience to be that of a referral. We want our patients and families to leave and speak our praises such that they return and their neighbors and their family members return when they're seeking care. And there's no referral like that referral. And so when we're able to do things that are patient-centered, that are tailored to the needs of our patients and families and improve the experience, we win. We win, and those dollars and cents roll in different ways. So to the point that Kristen suggested from this recent report that we just published at the association, we know that there are challenges that our patients and families of racial and ethnic backgrounds are experiencing discrimination, unfortunately, when they engage in dementia care. I'll focus our attention on the center top green block that suggests that racial and ethnic minorities, at a minimum, 33% or a third of them, have experienced discrimination in Alzheimer's and dementia care. That's our Hispanic population. And then we notice that other racial groups notice that as well, with increasing reports up to 50% from Black or African Americans. That is a challenge, to say the least. And that's a concerning challenge that we have a responsibility to address. Whether we are doing things that are unfortunately intentionally causing that discrimination, or if there's some way somehow that it is not being received, that we are trying to be patient-centered, that we are trying to be tailored to the needs of patients and families, we have an obligation to consider that in how we address and deliver care and change that stigma. We know that Black and African American communities are twice as likely to have an Alzheimer's diagnosis, but yet they only represent 13% of the population. So again, we have an obligation to do some things in terms of the education we provide, in terms of screening and delivering care that's culturally tailored to address those challenges and those disparities. And hopefully, as we continue to talk about this subject, we will see ways that perhaps you can tailor in your delivery of care personally as well as organizationally. And so again, how do we begin to deliver care that is culturally competent? How do we put on those lenses such that we see with those eyes, with that sensitivity in all that we do? I'll invite you to take a moment to look at what we call a diversity wheel. I will caveat that by no means is this all inclusive of all the angles of diversity and parts of personality that make up who we are, but it's a start. There are internal dimensions, the things that are innate to who we are, our age, our race, our ethnicity. And then there are external dimensions, the things that we inform in terms of our family dynamics, our income, our habits, the things that bring us joy. And then there's the things that are organizationally tied to who we are in terms of where we work, how we work, who we are in that space. And again, not all encompassing, but certainly a beginning. And as you take a look at these components and you consider who you are, and I'll ask you specifically speaking to who you are today, because these values and these preferences may change over time, and certainly do because we're evolving. I'll ask you to take a moment to consider who you are and what is most important to you. I'll turn back again to the wheel, but I'll invite you as you continue to marinate on those points to go to Slido, either using this QR code or going to slido.com and placing this code into the box there, because I'll have you add your points via word cloud, and we'll take a look and see what is most important. But I want to make sure everyone has a moment to engage Slido, and then we'll go back to the wheel so that you can see what some of your options are. Sorry. So here is our diversity wheel again. And again, I invite you to take a look and consider 2 or 3 things that are most important to you that really define and drive who you are today. Again, I'll give you the leeway that maybe that'll change next week, next month, but today maybe it's your anniversary. So your marital status means a lot to you. Or yesterday you got a raise, and so your income is something that really means a lot. Perhaps you just found out you're expecting a child, or perhaps your faith. We've had a series of holiday celebrations in many faiths. And so maybe your religion is what matters most to you. Or maybe you just ran a marathon or are preparing for one. And so your physical ability is something that means a lot to you. And so again, I invite you to take a look at the wheel and put into the Slido your responses. I'll give you about 30 more seconds to do that, and then we'll take a look together at what some of our responses are as a group. Excellent. So we're seeing some come in. It looks like our top answers so far. Well, we'll just go ahead and read them. We've got making a difference in the lives of others. I love that someone took some liberty there. Parental status, religion and parental status are among a couple that are coming in. Physical ability and faith, that seems to be also popular here too. I really like making a difference in the lives of others. That's awesome. Give a few more minutes if anyone else wanted to contribute. Recreational habits. What makes me me? That's a great question. And we may get into that later. I want to make sure this opportunity is available to you all. Education, cultural background. Awesome. Yeah, lots on parental status. It's been an interesting time to be a parent, and I can appreciate that many, for many reasons, may feel that is a huge part of who they are. Family as well. Awesome. Thank you so much for contributing. I'll go ahead and exit out of our Slido now and go back to our slide deck. I appreciated the comments and the offerings, and interesting that many of you shared some similar ones. And of course, some different ones as well. Physical abilities was noted, ethnicity and background, age was not noted. But as we consider this idea of the iceberg theory, there are many pieces of the iceberg that we can see, right? We can perhaps look at someone and suggest or guess that they are athletic by their build. We can make some assumptions or guesses about your race or ethnicity or age. But parental status, which was mentioned a lot, sexual orientation, behaviors, marital status, a lot of things that you all mentioned are not seen on the surface. I may or may not know whether you have children. I may or may not know if you're married, or what your status is at work or your income. Those things that matter most to us sometimes are the things that we can't see, but yet we make so many judgments and so many assumptions on those things that are visible. And as we consider this idea of the things that really matter and that really drive who we are, a lot of those things tend to be below the surface, below the opportunity to make assumptions or judgments, and really give us an opportunity to build relationship, to build connection with people. I don't know that your children matter to you or being a parent is important to you until I start to have a conversation and get to know you. I may not know that it really, really makes a difference to you that you want to be married or that you are married and you're enjoying that relationship until I get to build rapport and understand how valuable that is to you. And so when we think about cultural competence, when we think about relationship building and delivering care, it's important that we get beneath the surface, that we start to engage people, our patients and our families, on the conversations of the things that matter to them, that we ask those questions and we don't make assumptions, because we could really get into some sticky situations. And more than not even making assumptions about them, but making assumptions about perhaps the next patient or family we encounter, because the one we had 2 patients ago was just like this. They look just like them, same age, same race, so they must like the same things, or they might want the same care plan. Not necessarily, because we're all different. We're all a new experience and a new cultural, cross-cultural encounter, if you will. Just because we share the same things and beliefs and views doesn't mean that we interpret them the same or view them or value them in the same way. And so we can begin to look at people individually as one experience at a time, rather than a group of people who we know that wear this or look this way or walk this way or talk this way. Because we really need to focus on the one-to-one patient-centered interaction and recognize that every encounter we have is a cross-cultural encounter. Whether or not we grew up in the same neighborhood, looked the same way, went to the same school, you are who you are. And that experience, my time to engage with you, will be a different experience than perhaps the next person I meet with and the person after that. And so understanding that cultural competence really requires cultural humility, that we don't know what we don't know, but engaging in those conversations, having those connections will help us to get to a place that is more patient-centered and better care delivery. I want to take a moment to watch this video, and thank you so much for your patience as we toggle between screens. But I hope that this, a little less light, will really open our eyes to the idea of what cultural competence means and how we can apply that in our work. Take a moment for us to do a little digesting before I go back to the screen, and ask for your thoughts, perhaps in the chat, around that vignette. What were some things that came to your mind? How did that affect you to watch those scenarios, and to consider its application in this space of patient-centeredness? As we wait for any responses to come in, I know for me, looking at that video gives us a perspective into our patients' eyes. What is important to them? Things we may not know, things we may not comprehend. And as we consider the delivery of care that is patient-centered, that is culturally competent, It really requires us to step into our patient's shoes, to view things through their lenses, and to respect them from their perspective, to meet them where they are at. Please do feel free to add any comments you have as I return to the PowerPoint slides. One moment. And so as we consider what it means in our journey of cultural competence, it really is an opportunity for us to walk the walk of our patients. Perhaps we cannot take on their burdens, and nor should we, but we can certainly take on their perspective, consider the many things that they are juggling, the many concerns and burdens that are on their hearts, and how the delivery of our care can impact those circumstances, and how we can do our best to enhance rather than distract from their experience with us.
Eme, it's Kristen.
Sure.
I would like to read, it's actually coming in because we're on an app, so it's coming in through the Q&A section. So I'm able to see a couple of the comments.
Yes.
And one of them is, you never truly know what someone else is going through. Another is, everyone has their own story. This has incredible emotional impact. These video clips are so powerful, and asking for links to these videos because they're so moving. So thank you for that.
Thank you for sharing those. And certainly we will make sure that the clips are available. And I must say, it's certainly not my first time viewing that vignette, but there was something powerful this morning. And not that there's anything unique taking place in my life, but I think the reminder that it is truly a journey we are on with our patients. We are walking the walk. We have the ability to walk the walk with them in a space of cultural compassion. And that would be the best way that we could truly advocate and deliver care that is quality, is to have a heart that is culturally compassionate, culturally competent to their needs. And so how do we do that? We know that we want to do that, but so many things get in our way. Time gets in our way. Reports, pressures. There are a number of things that keep us from being that culturally competent, that culturally compassionate professional. And so how do we become that person 365 every day that we show up to work? One way I suggest is through improving our communication. That is the space and the place where we have to engage our patients. And as we do so with some greater intention, we can hopefully empathize in new ways, and with that empathy, deliver care that is patient-centered and culturally competent. This model is called the LEARN model, acronym for listening, explaining, acknowledging, recommending, and negotiating. And this is a part of our conversation, of our connection with our patients. We have to talk to them, right? We want to know what's happening and how we can support them. And so it's first listening with an ear and a heart of understanding to truly understand their perception of the problem. We may know clinically what the problem is, right? We have that training, and we can list the symptoms and the sequelae. But understanding how they perceive the problem is so important. I think of my friend and a friend who recently had to receive the diagnosis with her husband of dementia. And for the longest time, she did not know that dementia and Alzheimer's disease are coalesced. They are in the same space. Dementia is the umbrella, and Alzheimer's is one of the raindrops, if you will, of the illness. And so understanding that they don't have an understanding of their problem, or perhaps their understanding may need some finessing, but knowing where they're coming from, again, to the point of the video just shown, is such a powerful opportunity to see where they are and meet them where they are. Then explaining what you perceive as a problem, whether it's the diagnosis or the problems or the issues that they're bringing up, giving guidance around how or what you see is the issue. From there, acknowledging that perhaps you're not on the same page or finding the common ground. It's always easier and nicer to find common ground and to build upon that. But acknowledging perhaps where the gaps are, building upon those perspectives, and then recommending an action plan. It's so easy for us in our space of expertise, and I do use that in loose quotes or air quotes, to tell people, to give direction, to give prescription. But I like the idea of recommendation because we, again, may not be fully versed on everything they're returning to. Perhaps they don't disclose to us quite yet in this clinical encounter that they just lapsed in their insurance, or they just lost a job, or they don't have the means to pick up that prescription, or they don't have a neighborhood where they're safe to walk or to uh, access the things that we've recommended in terms of their care. So, recommending the plan, coming from a place of humility and suggesting, why don't we, or what do you think about? And then negotiating, find ways to be on the same page, to acknowledge that perhaps they aren't going to walk 3 times a week because they're not comfortable, or maybe they have multiple jobs, or they're not a walker, but maybe they'll bike, or maybe it won't be 3 times a week, but they can definitely work in one week or 1 time a week of this recommended plan. But coming to a mutual understanding and recognizing that maybe what your goals aren't their goals. When I think about perhaps the diabetes space, maybe that A1C number is not my goal. I just want to be able to enjoy time with my grandkids. So what does that look like? So we can both find ways that perhaps we don't get you to your A1C, but we certainly have you around to be with your grandkids. So we don't have you in the hospital. Maybe I don't want to be in a care facility. I want to be with my family until the end. Okay, well, how can we perhaps bring in some additional help for you? Or maybe we can bring you to the memory center a couple times a week, a day, adult day program. Whatever that looks like, finding mutual alignment so that there is compliance. Because we often think about non-compliance, and again, I place air quotes around that because we are not willing to hear and heed the concerns that our patients bring to us. But when we're able to listen and understand what their perception is, what's valuable to them, then we can come to a negotiation. It doesn't have to be clinically perfect, right? When I think about, again, the A1C situation, it doesn't have to be that number, but maybe we can get to a place where we're both comfortable, where we're both happy. Because at the end of the day, the patient is at the center of the care. It's not the other way around. I think we get really caught up in that, and we can really get ourselves derailed when we forget that the patients are at the center. And so it's important to remember that every encounter is a cross-cultural encounter. Again, beyond the cultures of race and ethnicity, but the culture of who I am, what defines me, as we talked about with the diversity wheel. Because every day is an opportunity to deliver culturally competent care to everyone, to every patient, to every family we engage. We don't have to wait for a visit or an audit to begin our cultural competence training or our cultural competence awareness and action. But this is something we should be doing every day because every patient, every encounter is cross-cultural and an opportunity to deliver care that is meaningful and that will bring people to a place of health. And so with that, I will open the door to any questions that we may have or any comments that you may have from the things that we have shared. Thank you for your time.
Excellent. Thank you so much, Eme. A lot of comments about those videos and how powerful they were. And also, just comments about wanting to share them. Someone had mentioned they wanted to share it on their personal Facebook page, not even their work page, just so that more people can just see that the emotions and just see what's important and how to inspire others. And someone else mentioned that video is from the Cleveland Clinic.
Yes, it is.
That's where that came from.
Correct.
We do have one question about we talk a lot about cultural differences in caring, right? So say you're in a facility and a family comes in. There's something that we need to do as staff members and as people who work in a facility, right, as well, to kind of understand that different families in different cultures take care of their loved ones in different ways.
Absolutely. And sometimes I have these conversations and people say, well, I've never met someone from Korea, or I don't know someone from West Africa or Nigeria. Great, you don't have to. You just met one right here, right now. Because to the points made earlier, every encounter is a cross-cultural encounter. And so I don't have to be versed in Korean heritage or Nigerian culture, but I need to be versed in this patient, and I can learn what matters to them. I think about many of my patients and family members or friends who may not adhere to all of the stereotypical or the outlined cultural nuances. Maybe I don't bow, maybe I shake hands, maybe I hug. That is going to be patient-centered and specific to that family and their needs. And so it's about having that engagement, having that dialogue, and finding out what their specific needs and preferences are.
It's interesting too, because you think about in the initial, conversations, either with a home health care or a facility or even adult day, asking medical needs, but asking who the person is, right? That's so crucial.
Absolutely.
I love that. Well, now no one's shaking hands, unfortunately. There's a lot less shaking hands now during COVID. But I'm talking about that kind of thing, right? What is your preferred way of greeting? I mean, I remember learning that, call this woman Mrs. So-and-so. Don't call her by her first name. It's insulting to her, something like that.
Absolutely. And I think, again, meeting people where they're at, that's such a key part of a conversation, is to allow people to dictate what that relationship looks like, because people will. You take the social cues from them. Maybe they call you Dr. Such and Such. Well, yes, Miss Such and Such. Or, maybe they embrace you. And so you just, maybe you're not an embracer, but you figure out how to do it real quick. Well, we can finally do that again. But people lead you with their cues. And so being culturally sensitive and socially sensitive, right? To pick up on those cues and to lean into that.
What are your thoughts about things that maybe some aides or people who go into the home can learn about before they kind of enter? I mean, you can pick up a lot of things by looking around, but
Absolutely.
what do you suggest that they could do as they head into a home?
Great question. I think that pre-assessment, that telephone assessment that often happens, is a first place to start. And I think people appreciate transparency when you say, Miss Jones, I'm excited to meet you on Thursday. Tell me about you. Tell me what matters to you. What would you like from this relationship? What would you consider to be important to you as I come and meet with you, as I come and provide care for you? And by no means will you be able to work through all things in that initial screen, but certainly, maybe that person values not having shoes on in their home. That will be plenty, right? To know at least, and to start and build from there. And as you mentioned, the home cues and other things will give you some tie-ins. But I think just opening the door of, I don't know you, but I want to, and I want to know and respect you and treat you and value you the way that you want to be valued. So help me to do that. And people, even when, well-intended, will respect that and appreciate that. And I think back to, the opening video, best intentions, people can feel that. People can feel when there's sincerity, and we all stumble, we all make mistakes. But I think when our hearts are in the right place, people can feel that, and they will help guide you to the right place for sure.
This is an interesting question coming in, talking about employers trying to respect the diversity in their staff. Can you kind of talk about the balance between wanting to get to know the staff without being too pushy as far as what's happening personally, that kind of thing?
Sure. Again, I go back to the social cues. I think placing space for people to feel included, to feel heard, to feel respected is number one. And then letting people guide you from there. They will let you know what they're comfortable with sharing. People want you to know about their weekend. Maybe it was with their children, maybe with their girlfriends or their guy friends. And so they'll start to share accordingly. And certainly you can lead with cue as well, that, oh, I want you to know that I'm a person beyond the 9 to 5. I've got 5 kids at home. I've got 20 grandkids, or whatever the case may be. And those things are valuable to me. And as you share them, people will feel comfortable sharing, or they won't. And that's okay too. And I think we all have to own our our okayness, our safeness, and being okay with what people are okay with. Because I think it's important that we recognize, the golden rule is treating people as we want to be treated, but the platinum or the cultural competence rule is treating them as they want to be treated and not imposing our beliefs and our desires on them, but respecting them where they are and letting them bring what they are comfortable bringing to the table.
What are your thoughts on talking about going back to a facility now and dealing with, learned so much in the sessions yesterday about really kind of not making those judgments quickly about what they're capable of doing. Is it more about, which a lot of folks don't have a lot of time to spend, they're so busy, everyone has so many people to take care of, et cetera, so much going on. Is there a quick way to try to get, I don't know, is there anything you can suggest on what's a great way to try to connect, with someone who is maybe a completely different culture than you are? And is it just to ask and just say, I really don't know?
Absolutely. And I think it is. I think it's, again, that transparent cultural humility, recognizing what you don't know, that you don't know what you don't know, but you want to know. And again, I think people really find sincerity and they have appreciation for that, that you're trying, that you want to know. And maybe, again, they're not ready. Maybe part of their cultural nuance is that they're not open. They won't share as much. And there's certainly not an issue with saying, okay, well, this patient was born and raised in this part of the world. Let me take a look. Let me Google. But, unlike our friend at the beginning, the opening video, not assuming, right? Maybe I don't like kimchi just because it's a part of my cultural heritage. Maybe that's the one piece of food that disdains me. And so you really doubly offended me, right? By making assumptions. But I think asking, to pick on our friend from the video, I understand that kimchi is a really popular dish. Are you a fan of that? Or have you ever had that before? What do you think of it? And getting people to guide you. Certainly, I think with the right heart, people will appreciate the fact that, oh, wow, you took the moment to look up some of our cultural dishes, some of our cultural nuances. I don't abide by those, but I appreciate the fact that you did that. Thank you. Here's what I do like. I love plantain. I love rice, but those other things don't resonate with me. And again, it's all about intention. I think our friend in the video would have well received that conversation with a different angle, right? With different intention.
Right. I think what the NBC, thanks for choosing a Connecticut
of course
a story there, that NBC story talking about that 1/3 of Connecticut's population, people of color, and then the different cities that have such large populations of people of color. What are some suggestions for maybe the organizations or some of these facilities, folks who are watching, the different organizations, to really, make inroads? And, we need, as we talk about, we all work for those of us here work for the Alzheimer's Association on the screen right now, and we are also really trying to embrace being able to serve more people of color, especially in the research field. So, what are your thoughts on maybe some of the folks who are watching, as some suggestions to really make sure we serve everyone who has this disease?
Great question. And taking it back to the special report we did at the Alzheimer's Association that speaks to perceived discrimination. And I won't say beyond just perception, that the outright question is, have you encountered that? And so whether true or false, to the point of perception, I perceive that as one of those members of those racial categories. And so I think perception is everything. And so if we are able to step back and say, well, how do we extend an olive branch to these communities? What can we do? Perfect illustration here at the association, we have many educational programs, maybe tailoring one to specific communities, many opportunities. We don't just have to wait for Black History Month for our Black friends and neighbors, or a Latino or Hispanic Awareness Month. Heritage Month. We don't have to wait for that. We can just tailor something that says, hey, we are going to have this education event on Friday the 12th. Come. And we'll also have someone who is Spanish speaking for our community, or we'll have someone who represents the Black community or Native American community. They will be highlighted, or we'll have a patient and a family that represents those groups. So again, people can see themselves in the dialogue. I recently had someone say to me, I didn't know that Alzheimer's disease affected Black people. And I said, oh, not only does it, but here's some statistics, right? And I think it's because people don't see themselves. They don't see the conversations. They don't see the dialogue around the fact that not only is it affect everyone, but here's the disparities, here's the challenges. And that may be part of why people feel discriminated against, because they don't feel included. And so having conversations, having presentations tailored to those needs. Those are some of the very things I'm working on with some of my health system relationships, creating spaces for those conversations.
Can we level set? I'm not sure that everyone actually knows the increased incidence among people of color of Alzheimer's and dementia.
Indeed. So, as was mentioned earlier on that slide where we talked about the special report, Alzheimer's disease affects African Americans twice as much, Latino or Spanish speaking persons 1.5 times as much. So again, considering that from a statistics point, those two groups of color are minorities, that's a problem. That's a major problem. And so why might that be the case? Perhaps because their providers of care don't know these statistics, and so they don't have these conversations. Maybe they discount the fact that the problems and the signs that they're showing could be related to dementia. Or again, maybe they don't know that it's not a disease that affects every population. And so they're not looking for it. They're not asking. They're not having that conversation. And so the patients may not even know to bring that conversation up either. And so there's education on both sides, making sure that our communities know that this is a concern and how to navigate that and advocate for that. And for our providers to know as well, this is a concern. And I need to bring it up with all of my patients equally.
And that's definitely what, I don't know if many of you guys remember, but last year's special report actually talked about that, right? That was the issue, the fact that there was a giant gap, that a senior would walk into a doctor's office and the doctor wouldn't ask about memory concerns and the senior wouldn't bring it up. So then what happens? How do you fill that gap, right? How do you change that? And we've had some different sessions on, billing for Medicare, for wellness and different things like that. So there's a lot out there. And I think we're definitely making inroads, but it's definitely something that we need to continue to talk about. And I have one more question for you. What would be your best advice on how we help eliminate some of the stigmas that are out there?
Well, we have to acknowledge it. That's number one. So this forum, this platform is key. Having this conversation, having it on the agenda, such that people know. Again, to your point earlier, so many people don't know. These statistics that came out in the special report are shocking because people simply aren't aware. And so bringing an awareness to that and then educating and training. We have to, now that we know, do better, do differently. And so having the training available to think differently, to be differently, to implement that, and to also, dare I say it, hold people accountable. And that accountability isn't punitive, but accountable to, the point I made earlier in the definition of organizational cultural competence. What does that look like? What does that feel like around here? Let's talk about that. Let's not just make it, a one-time hip hip hooray, we've checked the box, but this is a part of our monthly meetings agenda, our quarterly meeting agenda. We are talking about this. We're bringing up case presentations about where maybe there was opportunity to improve, or we did this really well, but making sure it's on the agenda. So talking about it, training about it, and doing better about it, if you will.
Excellent. All right, thank you so much, Eme. We are so pleased. What a great conversation to keep talking for a long time, but we greatly appreciate you and spending time and kicking off our day 2. So everybody, in between now and your second session, which begins, I believe, at 10:30, a reminder that if you applied for CEUs or contact hours, your participation is logged, so you really need to attend the session from beginning to end and fill out the survey that you're going to get post-session. Go visit the exhibitor booths, the chapter booths, tables, find out what the resources are out there. We have so many great resources here in Connecticut and so many things that are available to you. Download those grab those brochures and different things that people have to offer, and stop by and visit our chapter staff at our chapter tables as well. All right, have a wonderful day, and we will see you back here at 1:30 for closing. Again, thank you so much to Eme Martin, and we will see you guys later on. Have a great day.